Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds. I'm your host today, Eric Lim, and this is Premier Education brought to you at no cost thanks to our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. This week, it's a great delight for me to present Dr. Masaki Nakamura to talk about proton beam in the treatment for unresectable lung cancer. I understand that the proton beam has been in place in his hospital for over 30 years, and so look forward to hearing about your experience. Dr. Nakamura, over to you.
Thank you for your introduction. Today, I will be discussing proton beam therapy in the treatment of unresectable lung cancer. First, I would like to briefly introduce my institution. We as a National Cancer Center Hospital East, located in Kashiwa, about 30 kilometers outside of Tokyo. This is our main building, along with our surgery and endoscopy center. We also have an on-site hotel where some patients stay while receiving their proton beam therapy. Looking at the layout of our radiation oncology department, we have a photon therapy section equipped for linear accelerators. Next to this is the proton therapy section, where a single cyclotron powers 2 treatment rooms. The graph on the left illustrates our proton therapy patient volume over the years. Last year, we slightly reduced our patient numbers to manage the workload of our radiographers. However, after optimizing our workflows, we expect to treat approximately 400 patients this year. The pie chart on the right shows our treatment sites, which is heavily influenced by Japan's national insurance coverage. Currently, prostate, head and neck, lung, and pediatric cancers are the most common. I'm aware that within the NHS, adult indications for proton therapy are currently quite restricted. However, in Japan, we have been running a nationwide prospective registry study since 2016, standardizing dose fractionation across all domestic particle therapy centers. The real-world data from this registry has actually driven a gradual expansion of our national insurance coverage, which now include pediatric cancers, prostate cancer, hepatocellular carcinoma, pancreatic cancer, and early-stage non-small cell lung cancer. As you know, the greatest advantage of proton therapy over conventional photon therapy lies in its physical dose distribution. While X-ray doses peak near the skin surface and gradually deposit energy along their path, protons can be calibrated to deposit their maximum energy directly at the tumor site, the black peak, while delivering virtually zero dose to the deeper, healthy tissue behind it. For example, the figure on the right demonstrates spinal cord irradiation from a posterior approach. With protons, the anterior aspects of the spine and the vital internal organs are completely spared. Moving to early-stage lung cancer defined here based on the proposed TNM9 sedition as a node-negative solitary tumor 5 cm or less in diameter. According to NCCN guidelines, surgical resection remains a gold standard for operable patients. However, for medically inoperable patients, definitive radiotherapy, including proton beam therapy, is recommended. The current standard of care for these inoperable patients is SABRE. SABRE is a highly precise technique allowing for high dose perfraction and high central dose, which improves tumor control. For instance, key study comparing SABRE with conventional radiotherapy for stage 1 lung cancer showed that while adverse events were slightly more frequent with SABRE, but freedom from local treatment failure and overall survival were significantly improved. A randomized phase 2 trial was conducted comparing SABRE and PBT in high-risk patients, which were defined as central tumors, large tumors, or patients with prior history of lung cancer treatment. Although the target enrollment was 100 patients, unfortunately, the study was terminated early after only 21 patients were enrolled due to poor accrual. Insurance coverage appeared to be a major barrier. A systematic review and meta-analysis comparing SABRE and proton beam therapy has shown that protons significantly reduced radiation dose to the lungs and heart. However, there is no difference in prognosis or actual adverse events. This brings me back to our Japanese nationwide registry data for early-stage non-small cell lung cancer. We analyzed 309 patients of medically inoperable clinical T1 or 2 and 0M0 disease. The median age was 78 and 43% were treated based on clinical diagnosis. The prognosis and recurrence rate were entirely comparable to those in historical SABRE cohort. And the incidence of grade 3 adverse events were exceptionally low at just 4%. We consider this highly promising, especially considering that 25% of these patients had central tumors and 15% had concomitant ILD. In fact, we believe lung cancer complicated by ILD is one of the most compelling indications for particle therapy and a prime scenario for MDT discussion. As thoracic surgeons, you are well aware of the surgical risks in ILD patients. Even with SABRE, the risks are substantial. The Aspire ILD phase 2 trial evaluating SABRE for early-stage lung cancer with comorbid ILD. It reported a 1-year OS of 79%, but grade 3 adverse events occurred in 11% and fatal grade 5 events in 8%. In contrast, when we look at the ILD cohort within our Japanese particle therapy registry, the incidence of severe radiation pneumonitis was exceptionally low. The meta-analysis also supports this, demonstrating a significantly lower incidence of radiation pneumonitis in ILD complicated lung cancer when treated with particle therapy compared to photon therapy. Based on these strong signals, we are currently planning a prospective clinical trial evaluating particle therapy for lung cancer with comorbid ILD. Turning briefly to locally advanced non-small cell lung cancer. While neoadjuvant approach is followed by surgery or standard for resectable patients, definitive chemoradiotherapy remains a standard of care for unresectable patients. Naturally, there is strong interest in applying proton beam therapy here as well. The current standard radiotherapy technique is IMRT, which uses multiple beam angles to treat complex target volumes while sparing normal tissue. You may recall the RTOG 0617 dose escalation study, which was famously negative. A secondary analysis comparing conventional radiotherapy and IMRT from that trial shows that IMRT resulted in lower rates of grade 3 pneumonitis, despite the IMRT cohort having more advanced tumors and larger treatment volumes. When comparing IMRT directly to proton therapy in a phase 2 trial for locally advanced disease, proton successfully reduced dosimetric exposure to the lungs and heart. Yet clinical outcomes, specifically the incidence of pneumonitis and local recurrence, were not significantly different. These results are considered to be due to the poor outcomes in the early proton beam therapy group, which were attributed to a lack of proficiency of treatment planning. We eagerly await the result of the phase 3 trial, which was completed recruitment and should report its findings soon. Looking at our registry data for stage 3 lung cancer treated with protons, because this data spans from 2016, it includes patients from before the routine use of consolidation durvalumab. Still, 42% of the patients did receive immunotherapy following their chemoradiation. Notably, about 20% of these patients had extensive disease that would have been exceptionally difficult to treat with conventional X-rays. Our data suggests that even in these dosimetrically challenging tumors, proton therapy safely facilitates addition of consolidative immunotherapy, remaining a curative intent for patients who might otherwise be out of options. Finally, I would like to touch on future directions, starting with flash radiotherapy. Flash delivers radiation at ultra-high dose rates, achieving a unique biological effect that preserves normal tissue while maintaining anti-tumor efficacy. Numerous preclinical studies have demonstrated this protective effect across various organs, including the central nervous system, lungs, skin, and GI tract. Because the flash effect is not specific to one tumor type, its potential applications are vast. It also dramatically shortens treatment times, which will improve clinic throughput and greatly reduce the physical burden on the patient. We highly anticipate its clinical implementation in the near future. Another exciting frontier is NSEPT and PBCT, which built upon the principles of boron-neutron capture therapy. PNCT relies on the differential uptake of a boron compound between normal and cancer cells. Subsequent neutron irradiation triggers a localized nuclear reaction that selectively destroys the tumor. NSEPT leverages this by using the secondary thermal neutrons generating during standard proton beam irradiation to trigger a PNCT-like reaction in boron-loaded cells. PBCT similarly utilizes a direct nuclear reaction between the proton beam and boron-11 to emit highly lethal alpha particles. Both concepts elegantly aim to biochemically enhance the therapeutic ratio of proton therapy. Crucially, they offer a way to deliver BNCT-like effects to deep-seated tumors, which has traditionally been a major limitation of conventional BNCT. Thank you very much for your attention.
Well, thank you very much for an excellent presentation today. Can I ask, with regards to the randomized controlled trials which are being developed, comparing proton beam versus SBRT, what would the primary outcome be in those trials?
Do you mean this slide? Do you mean?
Yeah, and the future studies, what will be the primary outcome?
Future study.
Yeah.
Future study. I think the prognostic difference is not
Because if they compare survival, you will need a lot of patients.
Yes. So proton therapy is lower exposure lungs and hearts. So our primary endpoint is adverse events.
Adverse events, okay.
Yeah.
And presumably you won't compare survival differences between the two arms. It is assumed that the survival will be the same.
Yes, yes.
Okay. Can I ask for the treatment in Japan? The patients with unresectable lung cancer and ILD will benefit from proton beam therapy. But how do you select those without ILD? Will all patients benefit from proton beam therapy as well?
No, I don't think all patients have benefit of the proton therapy, but because national insurance covered inoperable patients, so the patients prefer proton therapy.
And why do they prefer proton therapy?
It's because They want proton therapy because innovative approach.
Okay. So how do you choose when to use proton and when to use SBRT?
Yeah. Mm, we select proton therapy especially centrally located tumor.
For central tumors, you use
Yeah,
proton?
yeah, yes.
Okay.
Uh,
Can I ask, you mentioned flash radiotherapy. It seems very new. Does it need a different
yeah.
machine?
No, no. Mm, but um, the no but flash is breakthrough treatment. So, but expanding treatment volume is currently unfeasible due to technical limitations of the system.
But you can do it on the same machines.
Yes,
Oh, okay, so it's a different setting on the same machine.
yeah, yes.
And
But
flash is radiotherapy, right? It's not particle therapy. It's not proton beam therapy. Flash.
no, no. First, can both proton therapy and LINAC, both proton,
Both are proton beam based.
yes, and LINAC can do flash therapy.
Right, so you need a linear accelerator though.
Both are. I'm sorry. Both machine can deliver flash radiotherapy.
Okay, so why don't more people use it around the world? Why is it still being evaluated?
Yes, yes. It's cu- currently undergoing prototype testing. So
It's still being
yes,
evaluated in
yeah,
prototype
yeah, yeah,
testing. Understand. Excellent, very good. Um, the concept of NCEPT and
yes.
PBCT, is that cone beam CT or what is that? You mentioned NCEPT in some of your slides. If you go further down your slides, you will
Yes,
see,
yes,
yeah, a bit more. This one, that's incredible.
yes, yes.
Is that neutron capture enhanced particle therapy? Does that need a new machine?
No, no, no. It's
Again, a
used.
linear accelerator is all you need.
No, it's used boron.
Proton beam therapy. Okay.
Yeah, yeah. Proton beam therapy.
Okay, great.
We need yes.
Dr. Atogi Banya is asking, is there no radiation pneumonitis for proton beam therapy?
Yes.
No, you don't
No, no, no.
you don't get radiation
Uh,
pneumonitis at all.
Proton therapy uh, reduce can reduce rank low dose rank exposure. So uh, severe grade pneumonitis was seen very few.
It's less common. Excellent. Well,
Yes, yes.
thank you very much for a very insightful talk. I mean, your experience with proton beam therapy in Japan is amazing. With over 30 years, most of the countries in the West have only very few years of experience with it. Next week, we're going to Professor Suresh Sanan, who's going to talk to us about radiotherapy in the management of resectable lung cancer, which leads me to thank our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. And once again, to thank you, Dr. Nakamura, for sharing your experience with us. Thank you very much, and
Thank you very
have a
much.
good day. Bye bye.